Early life origins of chronic obstructive pulmonary disease. Definition: COPD, chronic obstructive pulmonary disease, is an umbrella term used to describe progressive lung disease, including emphysema, chronic bronchitis, refractory asthma. This disease is characterized by increasing breathlessness.
Chronic obstructive pulmonary disease, pathophysiology and diagnosis. Cigarette smoking is by far the most common primary risk factor of COPD worldwide. According to global statistics, approximately 210 million people have COPD. By 2030, COPD is predicted to be the fourth leading cause of death worldwide. Epithelial cells lining the airways will respond to smoke inhalation by undergoing cellular changes due to long-term exposure. Over time, chronic irritation and inflammation of the air passages causes small airways disease and parenchymal destruction. Irritation and inflammation of the air passages causes constriction in the bronchi and bronchioles of the lung. In a healthy individual, standing at rest at the foot of a staircase while breathing normally, lung volume is well balanced in terms of IRV, inspirational reserve volume, VT, tidal volume, FRC, functional residual capacity. In the severe COPD patient, lung function is extremely imbalanced with only a tiny capacity for IRV. A patient with severe COPD has a very difficult time managing everyday tasks, such as stair climbing. The patient is asked to inhale and then forcefully exhale until the lungs are completely emptied via a tube attached to a recording device. The most important values from the spirometry readings are FEV1 and FVC. If the ratio of these values is less than 0.7, then COPD is suspected. More detailed results from spirometry can reveal the stage of COPD in the patient.
Applications in medicine. Fluticasone is a man-made steroid of the glucocorticoid family, which is related to the naturally occurring steroid hormone, cortisol or hydrocortisone, produced by the adrenal glands.
And you've been prescribed this inhaler for your breathing. It's called an elliptor. So what I'm going to do is just show you how to use the inhaler so you get all the medication down into your small airways where it's needed most. So just to remind you, there's a little dose counter window that you need to keep an eye on with every time you use it. This is a cap that just slides off, and that exposes the mouthpiece and also a little vent there. It's important that you don't cover that vent when you're using your inhaler, so holding it down the base would be good. When you place your mouth on the mouthpiece, make sure you've got a good firm seal with your lips. So before you breathe in, you need to empty your lungs comfortably, and then when you do breathe in steadily and deeply. Then at the end, hold your breath about 5 seconds or as long as comfortable before you take it out of the mouth. So I'll just show you. Okay, would you like to show me? Sure. Well done, that was really great.
Pros and cons. Pros. This design allows for drug delivery with long, steady inhalations similar to MDIs without a hand-breath coordination. This stand is in stark contrast to the quick, forceful inhalations required by other DPIs, and this feature is beneficial for patients who may not be able to inhale forcefully enough to effectively use traditional DPIs. Cons. When higher doses are used, fluticasone is absorbed and may cause side effects elsewhere in the body. The most common side effects of Brilinta are headache, upper respiratory tract infections, cold symptoms, and oral candidiasis or thrush. The average cost of one inhaler range between 300. Other important side effects are increased heart rate, blood pressure, and abnormal heart rhythms.
Use of the Ellipta inhaler. Step 1. Wash and dry your hands thoroughly. Step 2. Slide the cover down to see the mouthpiece. You should hear a click. Step 3. Every time you slide the cover down, a dose is loaded into the chamber. If you open the cover and close the cover again, you will lose that dose of medicine. Step 4. Exhale fully away from the device. Step 5. Put the mouthpiece between your lips and close your lips firmly around the mouthpiece. Step 6. Breathe in fast and deep. Step 7. Do not block the air vents with your fingers as you inhale. Step 8. Remove the inhaler from your mouth and hold your breath for 10 seconds or as long as comfortable. Step 9. Exhale slowly away from the device. Step 10. Slide the cover up over the mouthpiece and close it. Step 11. If your doctor has prescribed more than one dose, wait 30 to 60 seconds and then repeat the steps above. Step 12. Rinse your mouth after the last dose of medicine and spit the water out. Do not swallow the water.
Issue applied in Ecuador. A once-daily treatment regimen of combined fluticasone furoate and bilanterol was associated with a lower rate of exacerbations than usual care, and without a great rate of serious adverse events. In patients with COPD, chronic obstructive pulmonary disease, and a history of exacerbations, a recent study found.
It's a disease that affects the lungs and can eventually make the otherwise unconscious effort of breathing seem almost impossible. COPD, or chronic obstructive pulmonary disease, can do damage for decades without giving any noticeable signs that it's there until permanent and irreversible damage has been done.
Initially, patients will notice that they can't walk up hills, or can't mow their lawn, or can't do the shopping that they were used to. But as the disease gets worse, patients are more and more restricted. And the real severe cases, people are really limited. They are so short of breath they can't do anything else other than just sit in a chair and watch television.
72-year-old COPD patient Marvin Tibbetts describes how it feels to lose his breath.
To sum it up real fast, it's just like you're drowning. If you can visualize yourself underwater and you've expended all your air in your body and you need a breath of air, it's not there.
In the United States, tobacco use is a key factor in the development and progression of COPD.
Probably about 90% of patients who have COPD have a pretty clear history of cigarette smoking. It's been estimated that between 10 and 20% of patients who smoke regularly get COPD. But everybody who smokes is at risk. There are very good studies that show that if we are able to get people to stop smoking, the disease course will not be as bad as it would otherwise be. People will not go back to normal, but the deterioration in lung function over time will not be as bad.
Here is a typical example of someone who starts smoking when they are young. At age 18, the lungs are grown and completely open. No damage is evident. By age 28, there is a consistent cough, sometimes called a smoker's cough. By the mid to late 40s, lung function is beginning to be seriously impaired, and there is difficulty breathing with some simple tasks. By the 50s, people who perform physical labor, for instance, find it hard to continue this kind of work. And most COPD patients can't walk for long distances and can't lift objects. By the late 50s or early 60s, quality of life is severely impaired. COPD patients, assuming they continue to smoke, cannot do much of anything in the way of physical activity. The standard treatments for COPD are medications called...
Conclusion. Proper COPD management is crucial to help to reduce exacerbations and improve quality of life. From medication combinations to inhalation devices, there are new products offer patients effective, easier-to-use options for managing their COPD. While current guidelines make no specific recommendations in favor of these new products versus comparable ones previously on the market, these products do offer benefits for patients who have trouble with their current COPD medications or have problems with adherence. However, these products are generally more expensive than other products, and the higher cost must be weighed against potential benefits.
Treatment and management of chronic obstructive pulmonary disease, COPD. There is no cure for COPD. However, lifestyle changes and treatments can help you feel better, stay more active, and slow disease progression. The goals of COPD treatment are to relieve symptoms, slow the progression of disease, improve exercise tolerance, prevent and manage complications such as flare-ups, and improve overall health. Patients should become informed about COPD by speaking with their doctor. Sometimes a referral to a pulmonologist or lung doctor may be required. Patients who are informed about their COPD are likely to have better health outcomes. COPD interventions may consist of lifestyle changes, medical treatments, vaccinations, oxygen therapy, and pulmonary rehabilitation. A small number of patients may also require selective surgical procedures. Lifestyle changes are important. Quitting smoking is vitally important, and your doctor and support groups can help you quit. COPD risk increases with smoking and ranges from 35% to as high as 50%. Avoiding secondhand smoke and other lung irritants such as air pollution, dust, and chemical fumes is also very important. Getting regular exercise may also greatly benefit persons with COPD. Medical treatment of COPD may consist of inhaled medications and oral medications. The most important medicines used to treat COPD include inhaled bronchodilators, which patients breathe into the lungs to open up or dilate the airways, or bronchi. Thus, these medicines are called bronchodilators. Other medicines can be used with the bronchodilators in special situations and include inhaled corticosteroids, oral methylxanthines, such as theophylline, or oral phosphodiesterase 4 inhibitors. Bronchodilators relax the muscles around the airways, allowing the airways to open up more or dilate so that you can breathe better. Most bronchodilators are taken with inhalers, which allow the medication to go straight to your lungs. Using inhalers the right way is very important, and your healthcare provider or pharmacist can instruct you on their correct use.
Thank you.